Hello again, welcome to this session on measuring and valuing health outcomes. My name is Emmanuel Drabo. I am a health economist and assistant professor in the Department of Health Policy and Management within the Bloomberg School of Public Health at Johns Hopkins University. I am also a faculty of the Teaching Vaccine Economics Everywhere TVEE program. So today we will discuss how to define patient preferences. We'll also discuss instruments and effectiveness measurement. In part C, we'll discuss health utility measures. And then finally, in part D, we'll apply these notions to economic evaluation. We'll particularly explore the concepts of DALYs, disability adjusted life years, and the concepts of QALYs, the quality adjusted life years. So let's start with patient preferences. How do we measure and how do we value health? There's a distinction between these two, measurement versus evaluation of health. When we say that we're measuring health, we're thinking about counting, for instance, the number of deaths prevented, the infections prevented, the longevity, the quality of life, etc. But valuation is a different story. We're really trying to determine what is the value of avoiding an infection that is not fatal. What is the value of surviving 10 years without the infection, for example, instead of 5 years with infection? So there are preference-based measures of health status or conditions that we could use, and these incorporate the concepts of value. For example, QALY and DALYs, the quality adjusted life years or the disability adjusted life year concepts are going to incorporate these concepts of value. So how do we value health? There's a basic idea behind it. We're asking people to express their preferences for different health states. And then we use some methods to value individual preferences of different health states. There are several methods that we could use. There's a value trade-off in healthcare. There's an interest in delivering vaccine services that improve length of life without infection and also improve the quality of life without infection. So this may be, for instance, like two vaccine attributes that we care about, the length of life and the quality of life without the infection. So how can we construct a single numeric value that captures both these attributes of vaccines and that lead to prevention? That is really the core of the question of how do we do the value trade-offs in healthcare? So we can leverage patient preferences to do that. Rational decision-making requires risk, uncertainty, and trade-offs. We're going to assume, typically, that individuals are rational decision makers and that they're trying to maximize some preferences and that they're trying to maximize the utility that they derive from a given decision. And incorporating all these informations about risk, uncertainty, and the different trade-offs that they have to make. So the best vaccine is in part subjective based on the persons eligible to receive it and what condition they avoid. So it may vary, for instance, by age, by race, by income, by gender, and other factors. So we need a method that helps us quantify these trade-offs in a way that simplifies decision-making about vaccine use. Here's an example. Rational decision-making for patients requires trade-off, like the following. If we're thinking about HIV influenza vaccine, then we could think about short-term common side effects, such as pain, muscle aches, fever in children, or cost of vaccine. But if we're thinking about the long-term effects, we can think about the avoidance of HIV and the direct costs associated with it. And we may still contract another strain of influenza if we vaccinate. And there are some of the indirect consequences that are avoided. Now, the decision to proceed with the vaccination is going to depend on these trade-offs between the short-term treatment of vaccine and flu symptoms and the longer-term risk. So what does it mean to assess patient preferences and what concepts are important in doing so? To assess a person's preference for length and quality of life based on vaccine usage, we have three types of measures. We can value preferences. For example, how do you feel about one outcome for certain relative to another outcome for certain? This a classic example, a simple example would be on vaccination day side effects versus no side effect at all. These may be different depending on the individual's characteristic. We also use the measure of risk preference, meaning that how do people feel about one outcome for certain versus a gamble on another outcome. And then there's the notion of time preference, the measure of time preference that is going to be incorporated. How do people feel about a certain outcome today versus the same outcome in the future? So these are typically captured through instruments, and we call them instruments of effectiveness measurement. So there are methods to value individual preferences, and patient preferences such as value, risk, and time are generated by a number of techniques. The most common are what we call the visual analog scale, VAS. We also have time trade-off, TTO, and standard gamble. We'll walk through all of these. Imagine that you are at risk for polio, and of course, there is a vaccine for polio. So, having polio means that we have a long-term onset of paraplegia. We may have no pain. We may have paralysis from waist down, or may be leading us to be on a wheelchair, to be wheelchair bound. So let's see how we would value this health state using the different techniques. Now let's discuss instruments of effectiveness measurement. There are many methods to value individual preferences. Patient preferences such as value, risk, and time are generated by a number of techniques. The most common are, for example, visual analog scale or VAS, time trade-off or TTO, and standard gamble or SG. Suppose that you're asked to imagine that you are at risk for polio, and of course, there's a vaccine for polio. So if one experiences polio, if one has polio, then you may experience long-term onset of paraplegia, you may feel no pain, you may experience paralysis from waist down, and you may be wheelchair bound. Let's see how we would value this health state of polio using different techniques. So let's start with the visual analog scale. What is the VAS? The VAS is a scale that asks one to rate exactly how he or she feels, typically on a scale of 0 to 100, like a feeling thermometer, 0 being the state of death and 100 being the state of perfect health, and any rating in between, that's between 0 and 100 being some intermediary health states. So let's apply that to the VAS to COVID-19. So suppose that these are responses that we got from a bunch of respondents who said, one who chose that A, which is 100, B, another one who chose B, which is 80, and another one who chose E, which is 40, and so on and so forth. How would you value these different health states for these different respondents? Okay, we can do the same thing for polio too. On the VAS, we ask respondents to pick points on the thermometer where they would rate their health if they were to experience polio. And this might be a set of responses that we get. Now, the question is, how do we use the VAS to derive health value? Okay, which is what we call utility. How do we do that? So a utility is a health value that is derived using preference-based concept. So we can calculate utility from a VAS score by directly translating it from the linear measuring scale. So because we're asking a simple task, it's easy to use and interpret. In actuality, really, the VAS scores are not utilities. Okay, they result in value, but not in utilities. So it's not a true measure of utility because it is not preference-based, and it's not compared to death or alternative health states. So there's no trade-off that's being made here. There's no cost or consequences for making near zero, and there's no time horizon that is specified. For instance, do you have paralysis now or later? The concept of risk is not involved here either. So this brings us to time trade-off, which uses time horizon, and it measures preferences for the remaining life years in the current state, which could be, for instance, alternative 1 in the diagram, compared to fewer years in a higher quality state of being, which may be alternative 2. And then we ask the respondents which scenario do they prefer. So in the diagram here, alternative 1 could be that you have polio. This could be the polio scenario where you have you live in a lower health state, but for a longer period of time. Or the other alternative could be that you have shorter lifespan, but with perfect health. And how much are you willing to trade off those longer life years with polio, those additional life years with polio versus like a shorter lifespan without polio? Here's an example of a time trade-off. So imagine that you have early onset of polio. You can walk today, you are not paralyzed, and you have occasional weakness in the legs. The doctor says that you have 10 years until complete paralysis. But there's a potential cure. The successful surgery would prevent the symptoms indefinitely. But there's also a 50-50 chance that the polio onset in the X years sooner, okay? So which scenario do you prefer? How many years X sooner would you be willing to risk for the possibility of cure? So remember that you have 10 years until complete paralysis. So a cure gives you a 50-50 chance, better or worse, sooner. So do you prefer like 1 year, 2 years, 5 years, 7 years, or 9 years? So how many years would you be willing to risk? At the point of indifference, so meaning when you're in indifference between these two trade-offs, your value of polio cure is going to be 10 minus x divided by 10. Okay? And this is what is going to be the time trade-off value that we're going to be, the utility, or well, actually the value, the value that we're going to generate from the time trade-off. So time trade-off is used in the Daly's valuation exercise. Explicitly, it does address trade-offs between life and health-related quality of life for people with different diseases. It is also used in Daly's. For instance, the health state preference weights are elicited typically using the EQ5D survey instrument. And the EQ5D instrument has also the VAS component. And this is, for example, in the US and in the UK. The next method is Standard Gamble. In Standard Gamble, we're asking respondents to make a choice between a sure outcome and a gamble between the best or better outcome and the worst or worse outcome. So for example, the question may be framed in the following way. Imagine that you have early onset of polio. You can walk today, you are not paralyzed, you have occasional weakness in legs, doctors say you'll become paralyzed in next year. But there is a potential cure. So you could have a successful surgery that would prevent symptoms indefinitely. But there's an X% chance that you would die from the surgery. Then the process would require one to choose between a sure thing, which could be state I, the healthy state, and a gamble, some health state I, and a gamble between the best healthy state and the worst outcome, which could be death or some intermediary state that is inferior to state J. To state I. So the question would be framed this way, that it's basically what X chance of death would you be willing to risk for the possibility of cure? That's really what we're trying to quantify. It could be 10%, 25%, 50%, 75%, 90%. So at the point of indifference, your value of polio cure is going to be 1 minus the X. So we've learned about both standard gamble and time trade-off. So both standard gamble and time trade-off are preferred by many economists. The reason is because these techniques elicit preferences in a manner that is consistent with utility theory, a model for how people make decisions under conditions of uncertainty. In order for a decision to be consistent with utility theory, it has to involve risk, it has to involve uncertainty, and it also had to involve trade-offs. So here's the hierarchy of utility measures. So at the top of the ladder, we have standard gamble, and then we have time trade-off, and then we have VAS, visual analog scale. Standard gamble is the only true measure of utility. It involves choice and uncertainty. It does compare current state to death with a vaccine. Time trade-off measures only an element of preference not available in the standard gamble or VAS, which is time. VAS is the most straightforward. It is easy to implement because it's also less challenging for respondent. This brings us to part C, the different types of utility measures. So what is a health utility? When quality valuations reflect preferences, then they are referred to as utility weights. So these are quantifiable indices of health, captured on a scale of 0 to 1 and representing the extremes of death and full health. For example, the average American has a utility of 0.84. It is possible to have a negative score. For example, minus 0.05, which could represent a state worse than death, such as debilitating end of life with polio. These utility measures have scale properties. For example, a change from 0.4 to 0.6 is numerically equivalent to a change from 0.7 to 0.9. Here are some of the common measures of population health with vaccines. First, we have the quality adjusted life years, or QALYs. And second, we have the disability adjusted life years, or DALYs. These incorporate both survival and the impact of morbidity associated with different health states into a single utility index. This feature makes these measures useful for comparison across a range of infections, vaccine interventions, and populations. They're commonly used to compare vaccine interventions in cost-effectiveness analysis and cost-utility analysis. So let's start with health-related quality of life, HRQL. These are about the quality component. The morbidity measured in DALYs, or the quality of life measured in QALYs, components of an infectious disease contracted without the presence of a vaccine, are referred to as health-related quality of life units. We use utility weights or values that reflect population preferences for different conditions of health and diseases, for example, infectious diseases, injury, and disability. We multiply these by life expectancy, meaning the length component of the utility, and through different methodologies to produce QALYs or DALYs averted associated with different levels of health achieved with vaccines. So let's start with the quality adjusted life years. QALYs are the standard measure of a health utility for cost effectiveness analysis. They were developed in the 1960s by economists, operation researchers, and psychologists, primarily for use in cost effectiveness analysis. Utility weights are attached to individual experiences of health for either their own health states, referred to as patient weights, or the health states of others that are described to them, for example, community weights. QALYs are a measure of health expectancy, meaning by this, a good to be maximized. In 1993, the Panel on Cost Effectiveness in Health and Medicine recommended the use of community-based nationally representative preferences for use in cost-effectiveness analysis. There were several generic health status description and valuation survey instruments that became available to measure healthcare outcomes. The most prominent survey instruments are the Quality of Well-being Scale, the Health Utilities Index, and the Euroqual Group's EQ5D. Various countries, for example the US and the UK, have estimated country-specific preference weights using the EQ5D survey instruments. These were initially developed simultaneously in Dutch, English, Finnish, Norwegian, and Swedish, and are widely used in many countries around the world. They were also translated into most major languages. Following the successful rollout of the EQ5D, there were new versions that were deployed, the EQ5D 5L, and then the 3, 1 to 5 health states. So what are sources of quality weights? Well, we could link to US repository of the off-the-shelf access to a wide number of disease and condition-specific preference weights. The US repository is maintained by the Center for the Evaluation of Value and Risk of Health in Health Value Databases. So here are some examples. A perfect health has a value of 1.0. Pneumonia has a score of 0.954. Hypertension has a score of 0.789, and death has a score of 0. What about disability adjusted life year? The DALY. These were developed in 1993 by the World Bank and the WHO collaboration. The goal was to quantify the global burden of premature death, disease, and injury, and make recommendations that would improve health, particularly in developing nations. So the development of DALYs was founded on the principle or the concern with self-assessment of health, like it is done in QALYs, and is viewed as potentially misleading, particularly for cross-cultural comparison. So DALYs actually measure health gaps, so it is a bad to be minimized, unlike QALYs, which are goods to be maximized. So rather than creating a classification scheme of generic health states done in all other health-related quality of life, DALYs focus on the impact of a disease or condition on the preference of an individual. It's drawn from the International Classification of Impairments, Disabilities, and Handicap. The value of undesirable ICID-ish disabilities specific to diseases and conditions are generated by health professionals. It's developed by a panel of healthcare workers who met in Geneva. So DALYs are the preferred measure of vaccine outcomes. So we could think of DALYs as the sum of the year of life lost due to death and the years of life lost due to disability. The year of life lost due to disability depends on the weight factor that reflects the severity of the disease on a scale from 0, which is perfect health, to 1, which is equivalent to death. The weight factors are attached to specific diseases rather than to health states. Apart from the disability weights, the DALYs also include time discounting and age weights. So where could we get like the DALY weights? Well, the Global Burden of Disease 2004 update, Disability Weights for Disease and Conditions, provides some information. There are also some revised disability weighting that were published by Solomon et al. In 2010. Here is an example of weights for females 0 to 4 years old. So in perfect health, we could have 0. For measles, we could have 0.152. For congestive heart failure, we have 0.201. For death, we have 1. DALY country profiles are maintained by the Institutes for Health Metrics and Evaluation. How do we use DALY? We can use DALYs to answer how bad is disease X by counting up death or DALYs due to X. For example, how bad is polio? How bad is TB? We could count the death or the DALYs due to polio or to TB. We can also use DALY to answer how good is intervention Y by counting up death prevented or DALYs averted by doing Y. For example, how many deaths are prevented or how many DALYs are averted by providing polio vaccination or TB vaccination. Here are some of the 10 leading causes of DALYs. For lower income countries, the first number 1 is pneumonia, followed by diarrhea, and then we have perinatal conditions, major depressions, all the way down to cerebrovascular diseases. There are cheap ways to reduce population DALYs. Immunization comes on the top of that list, and nutrition supplementation, vector control and forcing traffic laws, tobacco control, sanitation, safe sex. These are all preventive measures. As you can see, antibiotics, antidepressants, which are more treatment and medication, comes at the bottom of the list. So prevention is much more cheaper way to reduce population DALYs. How do we apply these notions, these measures, to economic evaluation? So let's start with DALYs. How do we apply DALYs to vaccine economic evaluation? We can use them to measure health gap. Disability scale is from 0, no disability, to 1, death. So compared to a life with no disability during the maximum life expectancy. So recall that life expectancy is defined using life tables, and it may differ for females and males. It may also vary across countries. So for cost effectiveness analysis, we are interested in comparing burden of disease, meaning health gaps, with and without the new intervention. In diagram below, you can see, for example, that if we have on the x-axis age from 0 to the maximum life expectancy, and then we have the disability scale from death to the maximum health, then the health experience without the intervention could be represented by the curve, where there's a natural course that's happening. So the area above the curve is the health gap that could be reduced with the intervention. Here is the revised disability weighting from the 2010 Solomon et al. Paper that I referred to earlier. Let's start by looking at tuberculosis without the HIV infection. We can see here that we have 0.331 as the disability weight for this condition. So, how do we do the calculation of DALYs for tuberculosis? We suppose that out of 1,000,000 people, 100 people get TB at age 20, and 10 die of TB right away, and 90 survive, but they are sick for 1 year. And suppose that without TB, those who die would have lived to age 70. And 1 year with TB is equal to 0.67 years. The disability of TB, as I mentioned, and as we saw in the table, was 0.33 years. So the question is, how many DALYs were lost? Well, we know that death was equal to 10 years. And the year of the YLL years of life lost due to death was 50 years times 10 people. So that is 500 years. And the YLD years of life lost due to disability was 0.33 times 90 people. So that is 30 years. Putting these together, we get the DALYs, or disability adjusted life years, as the YLL plus the YLD, being 500 plus 30, which is equal to 530. So this was a rough way of calculating DALYs. But here's a correct DALY calculation with parameters. The formula is much more complex. The YLDs and YLLs are functions of various parameters. They are a function of the discount rate, 0 meaning that there's no discounting, and discounting captures the fact that life lost today does not have the same value as life lost tomorrow, or disabilities that occur today do not have the same value as disabilities that occur tomorrow. And then we have a parameter A, which is the age at death when we're calculating the YLL, and then the age at onset of disability when we're calculating the YLD. We have another parameter L, which represents life expectancy at age of death when we are calculating the YLL, and then the duration of disability when we're calculating the YLD. We have a beta coefficient parameter, which is the age weighting constant, typically set at 0.04. C is the adjustment constant for age weights. And here we're using a value of 1658. K is the age weighting factor, and it's a dummy variable taking the value of yes or no. No age weighting when we get 0, and then when there's the age weighting, we set it to 1. So typically we want to do some age weighting in our calculation. And D is the disability weight. We can also calculate the DALY weights at different health states. Modeling the DALY weights during the COVID-19 pandemic is difficult due to the lack of data. How do we calculate DALY weights at different health states? Let's take the example of COVID-19 pandemic. Modeling the DALY weights during the COVID-19 pandemic is challenging due to the lack of data. One way to mitigate this is to use DALY weights of diseases having similar symptoms to COVID-19. For example, we could use a disability weight of 0.133 available for lower respiratory tract infection, the health outcome of which is comparable with the case definition of COVID-19. We could also break up COVID-19 into different health states that I will describe below, and use the weights for the diseases with similar health outcomes. As you may be aware, COVID-19 has different stages, including the asymptomatic, mild, moderate, severe, and recovery stages. For the asymptomatic stage, we could, for example, use the Daly weight of 0. Here is a picture of the age-weighted Daly. This picture captures the value of a year of life. On the x-axis, we have different ages, and on the y-axis, we have the relative value of a year of life at any given age. For example, at age 10, we might have a value of a year of life which is between 0.8 and 1.2. And this increases up to around age 25 and then starts declining progressively. How do we apply QALYs to economic evaluation? Let's take a moment to look at this graph, which shows on the x-axis the duration in a given health state, and on the y-axis the health-related quality of life weights. This goes from 0 to 1, where 0 is the death state, and then 1 is perfect health. The health-related quality of life weight for each health state can be multiplied by the time in the health state, and then summed up to calculate the number of QALYs. QALYs capture simultaneously gains from reduced morbidity, meaning by this, so these are quality gains, and then reduced mortality, which are quantity gains. And then they integrate these into a single measure. For this reason, they are really appealing. The outcomes are assumed to occur with certainty in this figure. So without the intervention, the individual's health-related quality of life would deteriorate according to the lower curve. And then the person would die at time death 1. Now, with the intervention, the individual's health-related quality of life would deteriorate much slowly, and the person would die at time death 2. The area between these two curves is the QALYs gained by the intervention. On this figure, part A represents the QALY gained due to quality improvement, meaning the quality gains during the time that the person would have otherwise been alive anyhow. Part B of the figure is the amount of QALY gain due to quantity improvements, meaning by this the amount of life extension, but adjusted by the quality of that life extension. This table below is a study that Sullivan and Goshen conducted. They wanted to understand the preference-based EQ5D index score for chronic conditions in the United States as a community-based estimate. So they use data from the Medical Expenditure Panel Survey, or MEPS. What they find is that most chronic conditions, age, comorbidity, income, and education are all significant predictors of EQ5D index scores. Here are examples of QALYs. Calculation for meningitis. For an adult patient with asthma, we have 0.8 QALYs, the mean EQ5D index score in the Sullivan study. For influenza in year 3, we have a negative 0.031 QALYs, which is the mean disutility in Hallman. Let's look at an example of how to calculate QALY for meningitis, HIB, and meningitis. Suppose that for an adult patient with asthma, we have a 0.8 QALY, which is the mean EQ5D index score reported in Sullivan. Now, suppose that HIB influenza in year 3 reduces QALYs by 0.31. So this is the mean disutility in Hallman. And meningitis in year 4 reduces QALY by 0.0232, which is the mean disutility in Hallman. And then pneumonia occurs in year 6, resulting in a reduction in QALY of 0.0059, which is the mean disutility in Mohr. Suppose that death occurs in year 8. And furthermore, suppose that each year of aging contributes to a reduction in QALY of 0.00229, then we can calculate the QALYs over the lifetime of this individual up to age 8 up to year 8 when death occurs. So we start off with 0.08. And then in year 2, there's a reduction in QALY of 0.0029 due to aging, giving us 0.7997. And in year 3, we have not only a reduction in QALY due to HIV influenza of 0.031, but we also have a reduction in quality adjusted life years due to aging. So these two together leave us with a QALY of 0.7684 in year 3, and so on and so forth. Then we can discount these QALYs in each year and then sum them to get the total QALYs. Now, suppose that there's an intervention and that the intervention is effective at improving QALYs. And suppose that there's no health problem and that discounted QALY improvements are highlighted in red and that the person no longer dies at year 8, resulting in a total QALYs gain of 5.7594 versus the QALYs of 4.7895 versus the discounted QALYs of 4.4160 under the control without the intervention. So it's the same process. We live longer, we avoid onset of HIV, so we discount to 0.8 for 8 years, and the discounted QALYs are 5.76. The incremental QALYs gained by National Public Health Intervention would be then the 5.76 minus the 4.42, which is 1.34 QALYs gained per person. So, assuming that we have 500,000 children, then we'd multiply that by the 1.34 QALYs gained per person, and this would give us 675,000 QALYs that are gained by the intervention. Let's summarize this. There's a need to put a value on states of health other than death. Some of the tools to do this include the visual analog scale, the standard gamble, and time trade-off. We've examined all of these. Utility measures are quantifiable measures of the utility of a health state. They include DALYs and QALYs. DALYs and QALYs are similar measures of health, but DALYs do not require local measurement and are gap measures of health loss. QALYs require local calibration and are asset measures of healthy years lived. This is the end of this session. Thank you for following. On this figure, Part A represents the QALY gained due to quality improvement, meaning the quality gains during the time that the person would have otherwise been alive anyhow. Part B of the figure is the amount of QALY gain due to quantity improvements, meaning by this the amount of life extension, but adjusted by the quality of that life extension. This table below is a study that Sullivan and Goshen conducted. They wanted to understand the preference-based EQ5D index score for chronic conditions in the United States as a community-based estimate. So they use data from the Medical Expenditure Panel Survey, or MEPS. What they find is that most chronic conditions, age, comorbidity, income, and education are all significant predictors of EQ5D index scores. Here are examples of QALYs. Calculation for meningitis. For an adult patient with asthma, we have 0.8 QALYs, the mean EQ5D index score in the Sullivan study. For influenza in year 3, we have a negative 0.031 QALYs, which is the mean disutility in Hallman Let's look at an example of how to calculate QALY for meningitis, HIB, and meningitis. Suppose that for an adult patient with asthma, we have a 0.8 QALY, which is the mean EQ5D index score reported in Sullivan. Now, suppose that HIB influenza in year 3 reduces QALYs by 0.31. So this is the mean disutility in Holman. And meningitis in year 4 reduces QALY by 0.0232, which is the mean disutility in Holman. And then pneumonia occurs in year 6, resulting in a reduction in QALY of 0.0059, which is the mean disutility in Moore. Suppose that death occurs in year 8. And furthermore, suppose that each year of aging contributes to a reduction in QALY of 0.00229. Then we can calculate the QALYs over the lifetime of this individual up to age 8 up to year 8 when death occurs. So we start off with 0.08. And then in year 2, there's a reduction in QALY of 0.0029 due to aging, giving us 0.7997. And in year 3, we have not only a reduction in QALY due to HIB influenza of 0.031, but we also have a reduction in quality adjusted life years due to aging. So these two together leave us with a QALY of 0.7684 in year 3, and so on and so forth. Then we can discount these QALYs in each year and then sum them to get the total QALYs. Now, suppose that there's an intervention and that the intervention is effective at improving QALYs. And suppose that there's no health problem and that discounted QALY improvements are highlighted in red and that the person no longer dies at year 8, resulting in a total QALYs gain of 5.7594 versus the QALYs of 4.7895 versus the discounted QALYs of 4.4160 under the control without the intervention. So it's the same process. We live longer, we avoid onset of HIB, so we discount to 0.8 for 8 years, and the discounted QALYs are 5.76. The incremental QALYs gain by National Public Health Intervention would be then the 5.76 minus the 4.42, which is 1.34 QALYs gain per person. So, assuming that we have 500,000 children, then we'd multiply that by the 1.34 QALYs gain per person, and this would give us 675,000 QALYs that are gained by the intervention. Let's summarize this. There's a need to put a value on states of health other than death. Some of the tools to do this include the visual analog scale, the standard gamble, and time trade-off. We've examined all of these. Utility measures are quantifiable measures of the utility of a health state. They include DALYs and QALYs. DALYs and QALYs are similar measures of health, but DALYs do not require local measurement and are gap measures of health loss. QALYs require local calibration and are asset measures of healthy years lived. This is the end of this session. Thank you for following.